and thank you to Eunice for inviting me. Eunice and I actually first met at Cornell University, where I first became interested in school-based healthcare and school nursing. I'm not a school nurse myself, never have been, but a good friend of mine back in the early 90s was beginning a school-based health center, and so since I was casting around for a dissertation to do, I decided to do an evaluation and comparison of school-based healthcare, comparing school nursing services, traditional school nursing, to the availability of a school-based health center. And I did this utilizing a participatory approach, so I involved administrators and teachers and parents, because it was my hypothesis that the more we involved individuals who do not understand school nursing and what school-based health centers are, the more they would want them. And that actually worked in the community where I did this. We started out with 2 school-based health centers, and I believe now they have 6 in that community. So I don't know that my dissertation research was the sole responsibility for that, but I like to think it had a part. So I had the opportunity following that to do some examination of school-based healthcare in Australia and Canada. I already had a good idea at that point what we were doing in the U.S., and I thought, well, they must be doing it better. And I have some colleagues that I worked with in Canada and Australia, and we interviewed 73 what we would call key informants, nurses and teachers and administrators, community leaders, regarding how school-based healthcare was going, what they were doing, and the barriers to increasing the availability of school-based healthcare. We used the grounded theory approach and, of course, some qualitative analysis software, and we did a lot of back and forth via email, as you can imagine, because I couldn't spend a lot of time in Australia and Canada. I didn't have enough funding for that. We looked at current health needs of children, which all of you have talked about. Certainly we all know, in this audience in particular, what the health needs of children in school are and whether or not they're being addressed. We also looked at some specific health needs. In Australia, for example, they have a high incidence of skin cancers. So they spend a lot of time focusing on prevention, and you can see that their big hats are one way that they're approaching that. It's fascinating to see the children out on the playground because you just see a sea of blue hats, and if the children don't remember their hats, they have to go under one of those big sun sails that they have on every playground. So the children remember them because they don't like getting stuck under those. We have a lot of medication administration going on in schools, which some of you have already talked about. And we know that we don't have enough school nurses. One of the things that surprised me a lot, when I went to Australia and Canada, I thought maybe they were doing it better than us because they do have health insurance, but they're not. Depending on what state you're looking at, depending on which province, depending on school district, some of them have schools, many of them don't. And actually in Canada and Australia, I think they have less school nurses than we have here in the States. Again, it depends on the state. I just moved to Idaho, where it's particularly bad. I think some of you said Colorado and California it's bad. I think Idaho's probably worse. I've been there about a year. I came from New York, where school nursing is regarded pretty well, and we have pretty good ratios there, so I was really surprised. And we have exactly one school-based health center on site. It's actually linked to the school. It's not in the school in Idaho. And we have one mobile school-based health center. So I have a lot of work to do. I've moved to a great state to do that. We looked at healthcare provision and the models in the various countries, and we have a variety of models, as all of you know. Some schools will include school nurses full-time. Most don't. Most have some kind of a part-time status. In Canada and Australia, it was more common to see community health nurses going into the schools, so they weren't placed there regularly. They just came in and out as consultants, doing some education. Although I interviewed one principal of a school for children with special needs who said she had been there for 5 years and had never seen a community health nurse. And as you can imagine, they had many, many children with health care needs. The children with special needs issue came up in the research because many children in Canada and Australia, as well as the U.S., were not able to get the care they needed in school, and often they were being sent home or not allowed to come to the school because they could not provide the care that they needed. There was a great debate amongst the people that we interviewed as to whether or not there should be mainstreaming of children with special needs, because in the regular schools, it was felt they could not get the care they needed. So in Australia in particular, they send the children to special schools for children with special needs. And many of the parents like that, and the teachers like that, because they feel the children are able to get the care they need, whereas in a more public school, they would not be able to get that care the way they're structured right now. So it's a very interesting comparison. Their ratio of school nurses to students in Australia and Canada is, in general, much higher than it is here in the States. Again, that varies a lot by state. 1 to 750 is a general recommendation of the National Association of School Nurses, but then, of course, that depends on the acuity level and the number of children with special needs and what's going on in that particular school. So it's a very general recommendation, but we didn't begin to even see that in most of the schools that we were looking at. So I can talk about that for an hour, but I won't. Barriers to providing school-based health care were very similar across the 3 countries. We know that we have limited resources, and we often have a physician opposition to nurses' practice, particularly school-based health centers. We're not seeing that so much anymore in the United States, but we're seeing that a lot still in Australia and Canada. Nurse practitioners have increased or been allowed to practice to their scope of practice much more in the United States than they have been in Australia and Canada. It's still fairly new there. So they're going through many of the same battles that we had already had here. Teachers have expressed a lot of anxiety and stress with regard to the increasing expectations that they have for providing health care to children in schools. So particularly in Australia and Canada, where they have no school nurse on site, they're being asked to give medications, they're being asked to do G-tube feedings, they're being asked to do all of those things that school nurses would be involved in if they were there. And the teachers are starting to say, you know, I really don't have time to do this. I'm supposed to be teaching. And some teachers, particularly unionized teachers, are objecting and refusing to do that. Teachers that I spoke with in Ontario, for example, were refusing to provide the health care. Many of the teachers in Australia said, well, if we don't do it, who will? These children will not be able to come to school if we don't do it. We have a duty of care. So it's a really interesting dilemma and something that all of us know we need to work on. We saw differences in rural versus urban. The attitudes towards school nurses and school-based health centers continued to differ significantly between districts, whether they were rural and urban, sometimes because of very conservative points of view with regard to what school nurses do. We also saw the attitudes towards school nurses often were, well, they only put on Band-Aids. They just do Band-Aids all day, so we really don't need them. And this was among people like principals. One principal said to me, well, I don't want a school nurse here. I'll have kids lined up around the block to see her. Why would I want to be doing that? And I thought, because you have students that need to see her. Other structurally and culturally embedded issues included racism and classism. One principal, when being interviewed, said, well, the Aboriginal population likes sitting in the ER. They get to be in air conditioning and watch TV, so why should we provide care for them here? And this was the principal. So you can see we have a lot of issues that we need to work on. My only regret is that, like this conference here today, we're singing to the choir. All of us believe very much in this cause. What we need to do is get it out amongst a larger population. And so my participatory evaluation worked with involving parents and teachers so that they could then understand the differences and hopefully become advocates for us as well. Thank you.
Today I'm going to present a cost-benefit study of school nursing services. The study was published last week in Journal of Pediatrics. First, I'd like to use this opportunity to acknowledge all my co-authors for very important contributions. Actually, one of my co-authors, Erin, is here today. I will start with a little bit of background of this study. As many of you know, the demand for school nursing services has increased significantly in the past few decades. However, the funding for school nursing services has not. In fact, in the past few years, due to a budget cut, many districts across the nation has been eliminating school nurses, reducing their hours, or replacing them with untrained school staff. Several studies have evaluated the effects of school nursing services on students and teachers. On-site, school nursing services were found to be effective in improving student attendance, reducing early dismissals, and reducing teachers' time spent addressing student health issues. However, economic studies of school nursing services were very limited. In a cost-conscious era, knowing a public program is effective is no longer sufficient to justify spending. Given the growing pressure on education budgets, school nursing services need to be shown not only effective, but cost-effective. So the objective of this study was to conduct a case study of documented school nursing services practices to demonstrate the cost benefit of school nursing services delivered by full-time registered school nurses. Because of data availability, we chose the Massachusetts Essential School Health Services Program for this study. Almost every school in the program has at least one full-time registered school nurse, providing a wide range of school nursing services, such as direct care, health education, case management, policy program development, and oversight. All school nurses are required to submit a monthly activity report to the State Health Department. And the State Health Department will generate an annual data report, which shows all the school nursing activities that took place during a 10-month school year. According to the 2009-2010 data report, about 78 districts reported a total of 4.9 million student health encounters, 1.2 million medication administrations, and 1 million medical procedures performed by school nurses during a 10-month school period. The early dismissal rate after seeing a school nurse was 6.2%. Because program selection decisions or resource allocation decisions are typically made in the interest of society as a whole, so we conduct this study from a societal perspective. And the standard cost-benefit analysis approach was used to compare the essential school health services program with a no school nursing services scenario. The no school nursing service scenario is a hypothetical scenario in which we basically projected what will happen to student health services needs when there is zero school nursing services provided. The main data source for this study is the 2009-2010 Massachusetts report. We also used published estimates for certain parameter estimates, such as early dismissal rate without a school nurse, and the teacher's time spent with and without school nurse. We also used the physician fee and coding guide, the HCPC codebook, and the Massachusetts Medicaid schedule to generate some medical care cost estimates for the 22 medical procedures performed or reported by school nurses. In each scenario, we estimated 3 types of costs. First, the healthcare costs related to the medical procedures performed by school nurses. We basically assumed when there is no school nurse present at school, all those medical procedures will be performed or will be provided at a medical facility by physicians or nurses. We also estimated parents' productive loss costs related to student early dismissals and the medication administrations. In Massachusetts, according to the state regulation, if there is no nurse in the school system, parents have to go to school to administer medications for their children. The third type of cost we estimated is the teacher's productivity loss cost, which is associated with the teacher's time spent on addressing student health issues. Because lack of available data, we did not include costs awarded, potential costs awarded related to reduced 911 calls, reduced ER visits, and reduced hospitalizations. The program benefits were measured as costs awarded compared with the no school nursing services scenario. The cost of school nursing services incurred in the 78 school districts during the 2009-2010 school year were estimated and were measured as program costs, which includes nurse salary and fringe benefits, as well as the cost of medical supply and equipment. Cost-benefit measures include net benefits, benefit cost ratio, and all costs and benefits were measured in $2009. The results, under basic assumptions, at a program cost of $79 million, the estimated total cost awarded by the program was $20 million in medical care costs, $28 million in parents' productivity loss, and $129 million in teachers' productivity loss. As a result, it generated a net benefit of $98 million. for every dollar invested in the program, $2.2 was saved. In a sensitivity analysis, 10,000 simulation trials were performed, and in 95% of those trials, the total cost awarded ranged from $56 million to $302 million. And the benefit cost ratio ranged from 0.7 to 3.8. 89% of the 10,000 trials resulted in net saving or net benefit. The results of this study suggest that the Massachusetts Essential School Health Services Program was a cost-beneficial investment of public money and warranted careful considerations by policymakers, decision makers, when they have to make resource allocation decisions about school nursing positions. Because lack of available data, there are many other benefits of school nursing services were not accounted in this study, such as reduced 911 calls, visit hospitalizations, reduced health screenings by physicians, increased attendance, reduced dropout rates, etc. So the actual benefits of the program could be much higher. And some other school nursing services, like linking students to a healthcare provider, to insurance providers, and health education and health promotion, currently there is no way to estimate the economic impact of those services. So the findings of this study suggest that school nursing, the benefit of school nursing services could well exceed the cost of those services. School nursing services can be a benefit to many parties, including students, families, healthcare system, as well as the community at large. However, to achieve all those benefits, schools must have a full-time registered school nurse. In schools where education budgets are constrained, or school nursing services are low priority, education agencies may be able to work with healthcare system partners to explore other funding sources. And the healthcare system might value their contribution to this partnership as part of community benefit investment. My time's up. Okay, there are as many economic studies. This study has many has a few research limitations. However, we have, because of all this limitation, we have been cautious and have carefully conducted multivariate sensitivity analysis to address those limits. For future research, the analytical approach developed in this study can be used for programs in any other state or district. School nurses should regularly record their service activities and work with other school staff to collect data on school attendance, early dismissals, teachers' time spent, as well as 911 calls, etc. So when all those data become available, more research studies can be conducted to reflect more impact of school nursing services. Okay, I will stop here. My time is up, so.
Thank you so much for having me, even though I am a UC Berkeley alum. Go Bears! Just throw that in there. So I heard a lot of themes today around resources for school health services and how we make these programs sustainable. Unfortunately, I'm not going to provide you with a silver bullet. I wish I could, but I did want to present a couple of opportunities that we're watching at the state level that we think are really exciting for the state of California. So before I jump into that, I really wanted to quickly introduce our organization if you're not familiar with us. We're a statewide organization that is really promoting and advocating for school health services. Historically, that has been oriented around school-based health centers, but we are definitely expanding our mission and supporting the work of school health services generally, recognizing that a center is not going to be the right fit for every of the 10,000 schools in California. So right now we're working on a lot of our mission is our policy mission has really been oriented around integrating school-based health services into the healthcare delivery system. So we recognize that our state's healthcare system is evolving and making changes to how it's delivering care. And we think that there are some really exciting opportunities to lift up the school health model. And recognizing that school health services are about providing primary care and access, but also schools represent this really unique opportunity to provide preventative care, to do school-wide screenings, to do assessments, to do prevention work in a way that is really unique to a school-based model. So so my talk is really going to be around this healthcare system. I did want to recognize that there are a lot of policy changes happening on the education side of this world. We sit in a really interesting nexus between this crazy education system and this crazy healthcare system. So there are changes happening on the education side, like local control funding formula, like changes for billing for school-based health services that I'm happy to talk to, but I'm not going to focus on in this presentation. So I did want to talk about 4 policy changes. So I'm going to talk about the Affordable Care Act and the Triple Aim and what that means. I'm going to talk about accountable communities for health. It's a really exciting model of healthcare that the state is looking at. I'm going to talk about this preventative services rule, and then I'm also going to talk about school health services and managed care health plans. So the first one I'm going to talk about is the Triple Aim. The Triple Aim, if you're not familiar with this, is at the core of our healthcare reform efforts across the country. It's this idea that we want to improve three aspects about the healthcare system. We want to improve better healthcare, so better access to healthcare, better patient experiences of healthcare. We want to improve population health, so making sure that we are a health-oriented system and not a disease-oriented system. And we want to lower costs. This should probably be a bigger triangle in California, but that's the model we see. And I think that there's also an argument to be made that if we achieve all of those things, we are going to reduce health disparities. So this is at the core of healthcare reform, this idea, this concept. And part of this work is how are school health services relating to those 3 red pieces of the triangle. We know health services work. We've talked about that a lot today. They have an impact. School health services and school-based health centers have a positive impact on the health of students and the community. They decrease emergency department visits. They increase access to health care, so the extent that nurses are referring and making sure that their students are going to their pediatrician and going to their well-child visits. That's a part of access to care and better referrals. They can screen for diabetes risk factors. They reduce asthma-related hospitalizations. They increase healthcare utilization, which I mentioned. They can provide effective health education, so access to school classes and students to provide them information about what it means to be healthy, what it means to prevent diseases and to monitor chronic diseases if they happen to have them. They address some of the public health needs, so immunization, screenings, case management. So this is part of what we're seeing in school health services and how it relates to the Triple Aim. And I wanted to present this because these are things that the healthcare system is interested in. This is what, as the state is making changes, these are the pieces of the healthcare system that are really resonating and are guiding a lot of the transformations that that California is engaging in, as well as across the nation. So one of the exciting models of healthcare, of population health, is this idea of accountable communities for health. Our state applied to the federal government for funding to implement what we are calling our California State Innovation Model, our CalSIM. It's a model, it's an innovative model, it's how we want to transform our healthcare system. Bad news is the feds didn't give us dollars to implement this. We applied in the fall, we didn't get it. But I think a lot of what was laid out in the CalSIM is a baseline for California's vision of healthcare and what we want to see our healthcare system change. It's underlying a lot of some of the reform ideas that the state is moving and continues to move with. So one of the aspects of the CalSIM was this accountable communities for health. And there are states that are playing with this model. And it's a population health model. The goal is regionally, geographically defined pilots linking healthcare systems with community-based prevention strategies. So it's this idea that you want to take a defined geographic region, which can be a county, which can be a city, which could be a school district. So those are just some examples. To focus on one health condition, and some of the conditions that the state was considering were diabetes, cardio disease, which maybe doesn't resonate with this crowd, but asthma was one of the conditions. Also, mental health is a mental health issue in a community-wide, an issue for a community. And it partners, sorry, that's not what I wanted. It partners the healthcare system. So it takes the health plans, hospitals, primary care providers, county health departments, and merges them with the community partnering organizations like schools. So to merge the needs of the healthcare system with those that can be connected with the community and schools. So I think that this is an exciting model because it brings the healthcare system with the community to increase preventative care, to increase some of the screenings, to increase some of the school-wide education that we're seeing happening, and merging it together. So I think that this is an exciting community. And even though the state isn't moving forward with this idea, there are communities that are proceeding with these concepts. I know Fresno is one of them. I think this is an idea that resonates with a lot of foundations, and so there is an interest in different regions and pockets of California to see some of these pilots actually happening. So the third one I wanted to talk about, and I'll try to go through this really quickly, I'm running out of time, is a preventive services rule. So this was a rule from the federal government that allows reimbursement of preventive services when provided by professionals that may fall outside the state's clinical licensure system, so long as the services have been recommended by a physician or a licensed practitioner. So this is a rule that states can choose to adopt, and we see this as an opportunity to support some and reimburse for some of the preventive services that may be happening at schools, like screenings, like health education, and a lot of what we've heard in our school-based health centers is working with health educators, promotoras, it could be school nurses, that are doing some of this preventive work, that are doing some of this health education. So an opportunity that we see is moving beyond the preventative health education in a clinical setting between a doctor and her patients to some other models. Is there home visiting that we can promote? Is there group health education that we can promote? We know that you are doing this, so is there a way to provide reimbursement mechanisms for these services? Are school-wide screenings a part of this? Are schools a source of providing school-wide behavioral health screening? And so is that a part of this preventative care that we can see reimbursed through other types of providers at a school setting? So I'm going to try to go through this really quickly. The fourth one I want to talk about is managed care health plans. So our state has been delegating a lot of the healthcare delivery through managed care health plans. And so part of our work is showing and lifting up examples of where health plans are working and reaching out into their community to provide support. One opportunity is through the Children's Health and Disability Prevention Program. Managed care health plans are actually required to execute MOUs with schools in their area that they serve to support the provision of CHDP services. So this can be direct reimbursement, this can be health plans providing staff to the school and providing referral mechanisms for the school to make sure that students are getting access to the Children's Health and Disability Prevention Program. There's another model that I want to talk about, but I'm not going to jump into it. We can talk about it a little bit during the question and answer program, but where we're lifting up models of where health plans are actually partnering with school districts to reimburse school nurses or school-based health centers for preventive services. And one example is Kern County. The health plan there is working with the school district on an asthma management program where the school nurses are providing a 4-part program. That's what's included in the activities, and the health plan is actually reimbursing for their covered per component of that program per student that the school nurses serve that are enrolled in the health plan. So that's really brief. I can certainly talk more about that, but those are examples of this healthcare system that is engaged and wants to lower their costs and reduce emergency room visits and improve population health, and how we want to see schools become an integral component of those opportunities. So I apologize, that was really fast, but I'm happy to answer any questions, and those are some resources. Thank you.
Yes, so I'm going to try to be very quick. First, I need to thank Professor Rodriguez for this opportunity, and a lot of what I'm going to tell you today is based on the experience and the work of the Nurse Demonstration Project, and many of the speakers that spoke before me spoke very well of the issues that we're interested in looking at. So I'm going to move very quickly in the first couple of slides just because we've been talking about this a lot. They're mainly just a background information and justification for the project itself and what we're interested. We are interested in what, and it's good that my presentation follows Lisa's presentation because we have a state focus. So while it's interesting for us to look at what's happening in other countries, and the Australian experience, Canadian experiences are very interesting, we want to know what California can do and what other states are doing that might be relevant for the Californian experience. So, yes. To recap, this morning, basically, we had the problems, so many of the challenges is, first of all, the uninsured and the underinsured in California. So we covered this before. Professor Tongard was explaining that we have a decreasing number, but it's still significant numbers, but about 7% of the children are uninsured. So we want to know what we can do in regards to the uninsured and the underinsured, reminding ourselves that there is social disparities that are important, and the Latino population and Afro-descendants are affected in different ways with regards with the insurance and uninsurance. We also saw Lisa Chamberlain We talked about the needs, the increasing needs, chronic conditions, complex needs of children, what that means and what the reality is in the state. We talked about asthma and the increased number of cases where asthma implicates on not only the health but education attainments of children. So, from that background, where do we go? There are many ways to provide health services in schools. We also talked about health service or healthcare centers in schools, and we have, in the state of California, has made progress with regard with healthcare centers in schools, and the number of healthcare centers in schools in California has also increased. However, as you can see in this map, it doesn't solve some of the problems of disparities, regional disparities, and the concentration in urban areas, and I would say even wealthier urban areas. So we'd like to revisit the situation, the conditions that are provided by healthcare centers in schools, but we are focusing on another way to provide healthcare services in schools, and that is to have full-time nurses. And I'm sure you are familiar with this indicator, this ranking of it's called the ruler, that deals with the ratio of nurses per student. And California has consistently ranked among the worst in the country, with a ratio that varies, but it's basically depending on regions. Remember, this is also averages, so those regional disparities that I was telling you about are also significant in terms of the ratios. Okay, so focusing on full-time nurses and the impact of full-time nurses, what have those states that consistently rank above, the average in the nurse per student ratio done? What is the differential that those states are providing? And again, we also looked at the states on the bottom, the states that rank less, to see what their experience is and if there is anything that they are doing that we could be studying to see the relevance or maybe the viability of implementing some of those actions in California. Before we talk about what other states are doing, I just want to revisit some of the main challenges in California, so we can see if the experience of other states is relevant for us. So some of the challenges that we talked about this morning include, first of all, the budgetary restraints, and for many reasons, we heard from very early on the consequences of Proposition 13 and what that has meant in terms of full-time nurses and all the non-intentional consequences after that that have affected the school nurses ratio and the budgeting for school health services in general. We also talked, and I think this was again with Lisa, the need for a nursing data set. So currently we don't have a uniform method of collecting data for the state. So basically right now it's predominantly on self-reporting, district self-reporting data, and that gets some districts report data, are better collectors of data, some other districts are not, The data is different. So for any analysis, we need that data, not only to be collected, but also to be uniform. And also, this data has to be available, not only for those making the policies, but the wide public. We talked about regional disparities, and then we also talked this morning about what we call lack of cross-cultural communications and awareness, and this is when we have the principles. So when we have the case, the earlier, there were so many Lisas, I think Mike would be one of them, that we're talking about the the principles that do not recognize the need of healthcare services in schools, and principles that do not recognize the need for nurses, full-time nurses in schools. So that's what we're calling the lack of cultural and communications awareness. So what the other states have done, and this is, before I move on to this, I want to say this is not a solution. We are not necessarily recommending this, and I'll tell you in a minute why, maybe less than a minute. So one of the things that states have done when they realize that they rank among the worst in the country is to create a task force. A task force that constitutes, that brings together different kinds of expertise and different actors to discuss the situation and really draw some recommendations that could be implemented for a specific goal. And we put together this table that shows some of the states that used to rank or still rank among the worst, and you see Idaho is there. There you are. See, so Idaho is there. And what have they done? So they put in, they created a task force, and that task force has generated policy and might have contributed to the improvement. So you can see that there is some improvement there in terms of the ranking. New Mexico is there, and they have created this year a task force. However, New Mexico has consistently been above the average or the recommended ratio. Other practices that are also present in other states that could be relevant to California are legislation. So, for example, in terms of budgeting, school health can have a designated budgeting. This is the case, for example, in Vermont. It's not necessarily the solution, as task force is not necessarily the solution. We would have to see what of the recommendations from the task force were in fact implemented to see if they have results, but legislation is in the same case. Again, school nursing data set, so yes, information needs to be available and we need to be transparent about what's happening in the schools. We need to know what's happening in the schools. And then we also talked about partnerships briefly, and this is something that other states have been doing. Partnerships with universities, with hospitals, and with other institutions, even technology, development industry. So this is another area that is up for exploration, and some of the things that we are investigating and looking into to see the viability for California.